I'm Chris Brink. I'm the Director of Endoscopy. I'm here to moderate for the colon awareness. We want to focus today on colon cancer awareness. We have a panel involving several individuals, and we're excited to be here. And I'll be asking some questions. Does everybody want to go through and introduce themselves?
Sure, I can start. Hi, my name is Cliff Snellgrove. I'm a physician here at Arnot Internal Medicine, and I primarily practice outpatient primary care.
Thank you.
Hi, I'm Gokhan Uzuner. I'm a colorectal surgeon. I've been in practice for almost 30 years, and I practice at Arnot and take care of colon and rectal diseases.
I'm Sharon Cosgrove. I am a medical oncology social worker at the Fall Cancer Center.
Thank you, everyone, for being here. So I'm going to get started and start asking these questions for Dr. Snellgrove. What are some of the challenges primary care providers face when trying to get patients to have colonoscopies?
Yeah, that's a good question. And, you know, I can speak for myself in my practice. I think one of the biggest challenges is the trepidation some patients may have in actually getting the colonoscopy. I often hear patients talk about a relative or a friend or someone who may have not had the best experience with the colonoscopy or the preparation. And in those cases, I encourage them to really think about it. I let them know that this is a very common and safe procedure. It only takes a day out of your schedule. And I think if I talk to them and kind of explain how the process works, that seems to ease their fears when it comes to getting a colonoscopy.
Are there risk factors that the general population should know about so they're more likely to say, oh, I really need a colonoscopy. How do I get one?
Yeah, so there are risk factors. And oftentimes when we talk about risk factors in any disease, we separate it between risk factors you can change or modifiable risk factors and risk factors you can't change. When it comes to the risk factors you can change, there are several, smoking, a sedentary lifestyle, obesity, a diet high in processed foods or high in red meats. These are all factors that can increase the risk of developing colon cancer. Now, when it comes to non-modifiable or things we can't change, the main culprit in that situation is genetics. And I think that's where it's really important to talk to your doctor or provider, or even consider a genetic counselor if there's a significant family history of immediate relatives with colon cancer.
When you say immediate relatives, what are you talking about? Are you talking about a cousin? Are you talking about an aunt? Or are you talking about somebody closer?
Good question. The risk is much higher in first-degree relatives. So that would include parents, siblings, or children. If there's a history of colon cancer in the immediate family in that situation, then it's very important to talk to your doctor and get yourself set up with a colonoscopy and screening in that situation.
That's an excellent answer. And I just want to add, if you have a first degree relative with colon cancer, your risk is increased 2.3-fold. If you have more than a first degree relative, maybe two, your risk is increased 4.3-fold. And one of the important things is if you have a first degree relative who had colon cancer under the age of 45, then your risk is also increased 4-fold.
How old do you have to be for the first colonoscopy to happen?
Well, I think when it comes to someone who's average risk, not someone who has these immediate family members with colon cancer, maybe there's no history. The screening age is 45 at this time. Now, of course, that changes, as Dr. Uzuner was just talking about. If you have parents or siblings or children who've had colon cancer, under the age of 50 or younger, certainly in that situation, you want to get the colonoscopy either 10 years before the diagnosis of colon cancer in your immediate family, or at 40 years of age. So that changes in those situations. But for the average risk patient with, let's say, no risk factors, no family history, the newer guidelines are suggesting 45 years of age for the general population. Now, there are caveats to that, but 45 is generally the age we talk about now.
So if I wanted to come and schedule a colonoscopy, do I have to see my primary physician first?
So I think it's a good idea. And the reason I'm saying that is because most patients have some sort of medical history or maybe taking medications that to which an appointment with your primary provider would be the opportunity to talk about that. At least in personally speaking, when I see a patient who's coming in for a colonoscopy, I want to make sure, number one, that I have a good history, a family history, like we just talked about. I want to know their medical history too, and make sure that they're medically able to get a colonoscopy. In most cases, you are, and also go over their medications, because there are some medications that a patient may need to hold or modify before they get a colonoscopy. For example, if they're taking any sort of blood thinning medications, then that would be a medication they would need to hold in most cases before a colonoscopy. So I think it's important to see your primary before getting a referral to the gastroenterologist or colorectal surgeon in that case.
Well, I've had several individuals state that they have a hard time getting into their primaries. Sometimes they have to wait almost 6 months to get in. Is there some easier way of getting in? Or does the person call and say, well, I really want to get scheduled for a colonoscopy? Is there a better track?
Well, if there's a patient who has no medical history, no family history, not on any medications, there may be an opportunity in that situation to have a discussion to get an appointment for a colonoscopy, and possibly in those cases. I can say, in terms of access, certainly that's something we all need to work on. But even having a telemedicine appointment, just to be able to talk to the patient and go over those medications, that can be a quick and easy appointment. I still think it's a good idea, though, to get in with your primary care provider if you can, before getting set up with a colonoscopy.
If there's any difficulty of getting in with a primary care provider, you can also directly call me, like a colorectal surgeon or a GI, and directly ask for, having colonoscopy scheduled. So that's another alternative.
Now we know that Dr. Prasad just joined us, so thank you for joining us. We'd like to ask you a couple of questions. So what happens as a patient if I don't get a colonoscopy early on in life?
Good question. So there's a chance that if you don't get a colonoscopy, that you can grow polyps. Polyps are kind of the precursor to developing colorectal cancer. Now, not all polyps can develop into cancer, but a very common type of polyp that can grow has the potential to grow into a colorectal cancer. So if you don't get a colonoscopy, there are other ways to detect if that polyp is advancing to becoming a potential cancer. But without a colonoscopy, we can't remove any polyps that you have, and you're at risk of developing colon cancer if you don't get a colonoscopy to see if you have any polyps.
Why can't I just wait for symptoms before I have a colonoscopy?
A lot of times colorectal cancer can be totally asymptomatic too, but so it would be a little bit too late to wait for symptoms, because I would say most of the cancers would be presenting very late.
If we're late getting to going for the colonoscopy, what usually transpires or what happens? So we have symptoms now, and we've had our colonoscopy because of those symptoms. What are the next steps or the things that might occur because of it?
So yeah, hypothetical, we do a colonoscopy, we see something that looks like a colorectal cancer. My job as a gastroenterologist would be to biopsy the lesion and kind of confirm the diagnosis. Then I would probably refer them to someone like Dr. Ozuner to see if it is resectable. There would be more workup. You have to stage it from there. You would have to get a CAT scan. But at that point, this is when I would, Dr. Ozuner would or someone like a colorectal surgeon would now be incorporated into the care team to manage, as well as probably an oncologist.
Once colon and rectal cancer is diagnosed, a staging has to be done, and that usually for colon and rectal cancer, it's a little bit different. For colon cancer, we usually do a CT of the chest, abdomen, make sure there's no spread of the disease. And depending on what the stage is, either surgery is the preferable treatment, or sometimes we utilize oncology chemotherapy in adjunction with surgery. For rectal cancer, it's a little bit different. We want to stage them with MRI or endorectal ultrasonography. It's a very early lesion, or a combination of that included. And once the staging is completed, then surgery will be, the patient will be assessed for surgery or other treatment depending on the stage.
I've heard about Cologuard. I've even used it myself and wondered, what are the good things and bad things about Cologuard?
I can tell, and you, Dr. Pshav can add to it, or Dr. Skasko can add to it. Cologuard was approved in August 2014. It's basically a test to detect feces-based DNA biomarkers. These are abnormally methylated regions of DNA. I'm not going to go into details, but Cologuard is sensitive for colorectal cancer, 90%. And for advanced adenomas, when we say advanced adenomas, these are adenomas which are large, or polyps, which are large polyps, usually more than 2 centimeters or 20 millimeters. It's only sensitive 40% of the time for large polyps. So it's really not a screening test for polyps. It's more of diagnostic for cancer. So we see a lot, and GI sees that probably a lot too. Patients have a positive Cologuard, and then you do a scope, and then the patient has cancer. So yeah, it's a good test if you want to see if you have cancer, but it's not really a good screening test. So please elaborate on what I have said.
A Cologuard tells you that there is something there, and it's I was looking at the numbers. There's a 8 to 10% chance that you get a false negative. So if you're looking at 10 patients with diagnosed colon cancer, there's a chance that one person, that the Cologuard tells them that they don't have it. And then there's a 13% false positive rate, meaning you do it and there's a chance that there's nothing there at all. But then that always, the question that we have nowadays in GI is, why did it come back positive at all? Where did that positive come from? And that's where our guidelines are a little, that we don't have an answer yet. So that's, but yes, that is, a Cologuard is essentially telling you that there is something there. A colonoscopy can prevent something from ever developing, is the difference. A colonoscopy is not only diagnostic, it's therapeutic. It can take something out. A Cologuard is just a diagnostic. If it's positive, it's telling you that something is there. And you have to get a colonoscopy anyway to diagnose what it is.
When I'm seeing patients for that initial screening, I get the question a lot, can I just get the Cologuard? And I'd say, yeah, you can get the Cologuard. But, when I break it down, I tell them, well, nothing really beats direct visualization. So that's why I consider the colonoscopy the gold standard. And I strongly recommend it for patients. But if they're not going to do anything but the Cologuard, if I can at least get them to do that and get the ball rolling there, then that's what we'll do. But I always strongly recommend, direct visualization, to which the colonoscopy is the standard for that.
I know that we have mentioned a polyp several times and wondered who would like to kind of give a definition of what a polyp is, because I want to make sure our audience understands what it is.
Sure, I think I can elaborate on that. So, a polyp, polyps are on a spectrum. It could be benign growth of normal tissue, or it can be abnormal growth of cancerous tissue. and it could be anywhere in between. So a benign polyp is called a hyperplastic polyp. It's just regular colonic tissue that just seems to overgrow a little bit. It's hypertrophied, meaning just it's gotten a little bit bigger, but it is completely normal, benign. And then there's different types of precancerous polyps. Without going into too much detail, you have tubular adenoma, tubulovillous adenomas, villous adenomas. These are different types of precancerous polyps. And then within those polyps, when you take them out, a colonoscopy is, looking for these types of polyps specifically. And when you take them out, you want to see if the architecture of that polyp, meaning under the microscope, the cell structure of it. Now that's where the spectrum can the spectrum of the polyps can advance. Or what I'm trying to say is if the structure microscopically is not there, you can get something called metaplasia or dysplasia, and those are the steps towards developing a cancer. And that's what you're looking for when you take a polyp out: is what does the architecture look like under the microscope, and was this a high-grade lesion that was on its way towards becoming a cancer?
The polyp is an abnormal growth in the colon. Could be, like he said, anything benign or malignant. And so it's like a mushroom growth, could be flat, could be anything. They come in different size and shapes and forms. And one thing is, if you remove a polyp, or that's usually prophylactic, especially if it's a precancerous polyp, this is prophylactic against colorectal cancer, because it takes about 5 years for a clean colon to develop a polyp and 10 years to develop a cancer. So that's the logistics when we say, well, you had a normal colonoscopy, you should have a repeat colonoscopy in 10 years. Of course, when we say you have a normal colonoscopy, you have to have a clean colon, everything should be pristine, and you should have no polyps whatsoever.
Are there any preventative measures we can take to decrease the chance of developing colon cancer?
It's those talking about those modifiable risk factors, smoking cessation. If you're smoking, stop smoking. If you have excessive alcohol use, cutting back on alcohol use, exercising regularly, not leading a sedentary lifestyle, eating a diet that's high in vegetables and fiber and less so in meats, especially red meats. There's been some evidence there as well. Exercising regularly, these are all important parts of it.
There's also some data that aspirin and non-steroidal anti-inflammatory drugs, they prevent polyp formation. And we use them sometimes when you have some genetic diseases and you have a high propensity of developing polyps. So those are protective. And there's some risk factors too, other than what was being said, like radiation to the pelvis, if you had prostate cancer, GYN cancer or something, anything that required radiation to the pelvic area, your risk is slightly increased of developing rectal cancer.
How common is colon cancer compared to other cancers, Dr. Prasad?
So colon cancer is the third most common cancer in the United States between men and women, if you combine them both. Colon cancer is, I think, in 1 in every 23 men. And if you're going to break it down by gender, it's 1 in every 23 men and 1 in every 25 women.
And also, it's the third most common death due to cancer in men after lung and prostate, and in females after lung and breast. So it's not only the third most common cancer, it's also the most common cause of death due to cancer.
I heard that there has been an increase in colon cancer in New York State. Is that true, especially in the younger population?
I don't have the data for New York specifically, but I know in general, yes, we are diagnosing colon cancer in younger and younger patients. That's why recently, just a couple of years ago, the colon cancer screening age was decreased from 50 to 45. And, speaking anecdotally, we have seen some large, high-grade advanced polyps in patients as young as 29 years old. Just so, yes, it's becoming more and more common. Is there something environmental that's contributing to that? I don't know yet, probably, but yes, we are seeing it in younger patients.
Is race and ethnicity important in colon cancer? Is that a huge factor?
So I believe the data says that African Americans are more likely to have colon cancer. It's just what I read, but I think we've seen it in every race in our practice. But according to the data I read, it seems like African Americans are at higher risk.
I can elaborate on that. He's right. The African Americans have it's slightly higher, and the death rate, mortality is higher. Hispanics also have a higher incidence, and and also the native Hawaii, the native Indians, they also have a higher risk. Now, this may be due to several factors: not being able to get to a healthcare facility, not following up with screening modalities. There may be several reasons for that, but the incidence and mortality in those groups is higher in general.
I only have a few more questions. Some of them are geared towards rectal cancer, and I didn't know if Dr. Ozuner wanted to say anything else. I know that we've covered quite a bit in this session.
I think we covered quite a bit. I just wanted to, rectal cancer is slightly different than colon cancer in regards to staging, which I elaborated before, and also on treatment. Depending on the stage, the treatment for rectal cancer could be surgery or could be a combination of chemotherapy and radiation therapy. And sometimes with, depending again on the stage, with the chemo and radiation therapy, the rectal cancer may disappear, and we just watch and wait, observe this patient, make sure it doesn't come back. So that's one route or one pathway of treating rectal cancer. If it's a very early rectal cancer, for some reason the patient is unable to have radiation, maybe they had prostate radiation or some other sort of radiation, could be a female who had radiation for a GYN pathology, then surgery is the preferred treatment. So it's a little bit slightly different than colon cancer, where in colon cancer, if you don't have metastatic disease, the primary modality of treatment is surgery.
I'd like to change our focus just a little bit regarding emotional and physical support. And we were wondering what is out there in our community that could help us after the individual finds out that they have colon cancer, and how they're reacting and creating that type of stress and frustration. What are their next steps, or what do you see? And this is for Sharon.
So I don't think it just is focused on colorectal cancer. I think anybody that is diagnosed with cancer is going to be going through a whirlwind of emotions, helplessness, anger, sadness, confusion. Really, the first person that they're looking to is the gentlemen, for example, that are on this panel. They're looking to them for direction of where I go next. And they're looking for not just that part of it, but they're looking at what resources are out there to help me adjust to this diagnosis, make a plan. They're looking for how they can help their family, their friends. They're looking at a host of different things. But right off the jump, what I would say to people when they have a diagnosis like this is you rely on your medical team to direct you to the experts that are going to be able to address this. And then the team that you will find within oncology and or within the medical team, you're going to find that whether it's social workers like myself or case managers, there are support groups, there are peer groups, there's peer one-on-one kind of supports. there's counselors, there's other things that are out there. There's also a lot of non-traditional services that are out there, like massage and yoga, that people are turning to, and that we can give them information on to help support them as they are working through the reality of their diagnosis.
How often is there a barrier when asking family members to help with this loved one?
I don't think families generally are a barrier. I think the barrier is usually the patient themselves not wanting to ask for help, not wanting to overwhelm their family, not wanting to put a burden on their family to have to help take care of them. Or, what I see with a lot of patients that come here is they don't want to tell, whether it be their son, their daughter, or, even their mother, their father, they don't want to tell them really how they're feeling and the emotions that they're going through, because they don't want to worry them. They're not only taking on their own emotions from the diagnosis, but they are trying to protect their family. So it's not really that we see that families aren't willing to be supportive and step in and be a huge, caregiving support, or, a source of assistance, care, whatever. It's really getting the patient to understand that they're not burdening them by letting them know what they're feeling, what they're thinking, what their fears are, because that's what families are going through too. When they hear that somebody they love has been diagnosed with cancer, they have their own host of emotions that they are also trying to be protective of that person. So it's kind of, that's where there's a barrier sometime in that communication.
Do you feel that brings some families together?
Oh, absolutely. You definitely see that if there's, not all the time, but you definitely see when there's maybe been some divides in families, that when something like this happens, people will come forward and want to get more engaged and want to assist. The difficulty with that, though, is that usually if there's a divide in the family, there's a reason for that we don't know. We're not privy to, nor do we need to know that. And some of those divides don't just go away. Some of those issues don't just go away because there's a cancer diagnosis. And so those can become a challenge in and of themselves.
Are there any other thoughts that you would like to share with us, Sharon?
I think the biggest thing that people need to understand is that regardless of your age, regardless of your race, regardless of your diagnosis, a cancer diagnosis is a journey. It is not something that's going to be an overnight thing, and it's not something that you're going to be able to manage on your own, which is why you have a team. And that team includes your medical professionals, it includes your family, it includes your friends. It's important that you realize that you're not alone, that families realize that they're not alone. There's no right or wrong way to cope with this. And it's something that more people than you know are dealing with on an everyday basis. And by asking for help is the way that we can all work together to really help people navigate through that journey.
Dr. Snellgrove, if there was anything you wanted to share with the team and your community regarding colon cancer awareness, what do you think would be the top thought?
Just say normalize the conversation talking about colon cancer, and make sure that you're up to date and you've talked to your primary provider about screening. And two, if you, no matter what age, if you ever have symptoms that are abnormal, that are lasting for a long period of time, changes in bowel habits, blood in the stool, things like that, take it seriously. Go to your doctor, talk to them about it, because there are options available.
Dr. Person, what would be your top thought?
I chose this profession because the one thing I really like about gastroenterology is that it can prevent cancer. Colonoscopies can prevent cancer. It's one of the only things in medicine that can, prevent cancer. So I really would like to stress that. I know the idea of a colonoscopy to most people is not like something appealing, but when the alternative is, possibly finding a cancer and dealing with it early before you have to deal with the stresses, the life-changing diagnosis that it really is, it's really not that bad in comparative terms. So that's one thing I would like for people to know, is that it's one of the few tests that we have right now in medicine that can stop this from happening. And that would be my final thought.
Sharon, what would be your final thought?
My final thought would be for people to realize that they are not alone in worrying about cancer. They're not alone in facing the reality of cancer. There's a lot of resources in the community, and if there's questions, they need to ask. That's the most important thing. If they have questions, concerns, they need to ask.
Well, thank you. I can tell that there is a lot of passion here. Is there any other questions or thoughts that we want to share?
Patients should understand colon cancer is curable, and it's, especially if it's diagnosed early, and it has a very good prognosis. So I want to kind of concur with everything that has been said. Please do the screening, because even if you have cancer, it's totally curable and you would have a excellent prognosis.